Jakob, we're doing pulmonary embolism again. Why are we doing this again?
Well, I think we had some recording issues the first time, and also I didn't really know how to speak on a podcast at that time, so there was a lot of rambling and ranting. I can't promise there won't be any today. I'll do my best.
I still don't know how to talk on a podcast, but we've learned a little bit after a year. Oh, is it a year? Well done.
Yeah, I guess exactly a year, yeah.
So we will have a fun time reviewing pulmonary embolism because one, it's pretty common. It is more common than people realize, and it's World Patient Safety Day, and this is relevant.
So it's one of the most common causes of sudden cardiac-related or cardiovascular-related death in North America. So I think a lot of the cardiac arrest patients that we're managing or things like that might actually be a PE kind of underlying everything, but that often go unnoticed, right?
Yeah, because your first assumption in the pre-hospital setting, if someone's in a cardiac arrest, especially if they're older or mid-age, is not pulmonary embolism. So we'll do this at a different lens because you and I both like this. This is both on our backgrounds as well. We'll talk about the patho and the treatments of pulmonary embolism, but we'll also look at a different lens, such as patient safety and human factors, because I don't know how common that is discussed in the pre-hospital setting. And because we're nerds and like that stuff, we will chat about it.
Yeah, I think that looking at it from those two angles is going to be a really interesting way to have this conversation today.
Well, tell me everything you know about pulmonary embolism. Go.
Okay. Well, we can start with the pathophysiology of pulmonary embolism. So pulmonary embolism really is most commonly, it's a blood clot, which is starting off somewhere like in the peripheral vasculature. So this will be like a DVT, a deep vein thrombosis, which then embolizes, becomes a PE later on when it lodges into the lungs. Obviously, you can have a pulmonary embolism that is not from a thrombus. This could be like a fat embolism in the setting of a fracture, amniotic fluid embolism in the case of like a pregnancy complication. Today, I think we're going to focus on the more common form of PE, which is venous thromboembolism. So these, like I said, DVTs that embolize the lungs, the DVTs most commonly form in the the calf veins, which are like the tibial and fibular veins, or the more proximal veins in the femoral veins and the iliac veins in the pelvis. So depending on the size of the clot, the PE might end up being a small subsegmental or segmental PE. So this is where like the clot travels through the heart, and in the absence of an ASD or VSD, the only place that it can go is the lungs. So if it's a smaller clot, it might just block off a small segment of the lungs. And if it's a really big clot, it might block off all of the lungs. I'm going to cut myself off from ranting about that. Any questions or thoughts on that section?
No, keep ranting. Let's hear it.
So one important consideration is what are the risk factors of venous thromboembolism and pulmonary embolism? So the patients that are the most at risk of this disease are those presenting with the Virchow triad or a part of the triad. Everyone hears this in school and like, what is the Virchow triad? What does it mean? Well, it's comprised of three components, which are hypercoagulability, venous stasis, and endothelial injury or tissue damage. So hypercoagulability, what does that mean? Well, it means that you are more likely to produce blood clots. You're thrombophilic or lover of clots is another word for it. Now, there's an inherited hypercoagulability that patients may present with. These are often kind of gene mutations. So patients can present with factor V Leiden. They can have a deficiency in protein C and S, which are kind of balancing. They kind of balance our coagulation and anticoagulation cascades. And antithrombin 3 deficiency. Antithrombin 3 obviously binds to thrombin and makes it inert. So if you're deficient in that, you're going to have some hyperactive thrombin ready to go and cause a clot. Hypercoagulability can also be acquired in the context of malignancy. So cancer, patients with cancer, much higher risk of developing blood clots. Patients who are pregnant through higher levels of estrogen, and patients who are on oral contraceptives through a same kind of pathway. Patients with antiphospholipid antibody syndrome can also present with hypercoagulability. And notably, any patient with a hyperinflammatory state will present with a higher risk of blood clots and thromboembolic disease. So think of your septic patients, think of your post-trauma patients, and those are going to be a multi kind of factor presentation. You can see it'd be really easy for a patient to have kind of all three parts of this triad, right? You have a cancer patient who's been immobilized and just had a mass excised from somewhere. So they have the tissue damage from their surgery, they have venous stasis, and they have hypercoagulability from their malignancy.
There's so much good stuff in there. Let's unpack it, because like when we were at school at the academy, the classic scenario of this was, hey, you get called to an airport, but somebody was on a 24-hour flight and they hacked a bunch of darts and they got short of breath with calf tenderness. You're like, okay, I know what this is. But that's classic textbook, which is risk factors, because you have the stasis there, you have the inflammatory response, but you can see how common it is when you have people with malignancies such as cancer at higher risk of it. Oral contraceptives, like anecdotally, I could tell you, I've seen a handful of patients on oral contraceptives and smoked as well that had signs and symptoms of a pulmonary embolism. So there's a multitude of different types of people that could experience it. And you can see why, again, this is so common in the pre-hospital and the in-hospital setting sees these patients. So what do you think is the best way we could risk stratify that this is a PE versus this is something else?
Yeah, I think that like with everything else, it's all about having these risk factors stacking up on top of each other, right? So maybe if you have one of these risk factors, you can go on with your life without having a VTE. But it's when, you have one of these risk factors and then you have disease or illness that then compounds your risk. So that kind of gives you your pre-diagnostic kind of probability that this patient is presenting with a PE is those risk factors that are present. And then in terms of physical exam and, exam findings, it's a really difficult disease to uncover, right? Because patients present with sudden onset shortness of breath, which might not always be super sudden, especially if they had like multiple small PEs that eventually led to high enough clot burden for them to be really sick. They could be kind of like a stepwise presentation, or it could be just sudden cardiac death, right? They had a massive clot embolize and now they're VSA with the PEA. So it can be quite challenging to diagnose this, especially in the field without, tests like a D-dimer or, CT scan. But looking for sudden or stepwise progression in shortness of breath with pleuritic chest pain, and then tachypnea, tachycardia. And this is really the key finding for me is hypoxia with clear lung sounds. So typically patients with hypoxia, they're going to have wheezes, they're going to have crackles, they're going to have congestion, they're going to have absent breath sounds somewhere. There's something going on typically that we can auscultate or, find with a chest exam. Ventilation is not affected. It's the perfusion side. So they will have clear lung sounds. With the peripheral signs of DVT can help you kind of figure out what's going on.
I remember we had this discussion before, and just operationally, seeing it in real life, when you look at someone and they look labored, you're like, you look distressed and your lungs are clear, it's like something's going on. You have a PE or something metabolic's going on that you're compensating this vigorously. And once you see it and you hear the clear lung sounds, you're like, that's a red flag for me.
Yeah, it's almost comforting when you hear that, wheeze or something else going on. It's like, okay, now I understand what's happening. We can fix this. But yeah, you definitely need to dig deeper in that context for sure.
It's like when you think it's a diabetic emergency and you take a blood sugar and they're not hypoglycemic and you're like, oh, what else is going on now?
Like, oh, this differential just got way, way wider.
Yeah.
Yeah.
I want to look at this because I'm thinking about how you said to risk stratify and pile evidence on top of more evidence to grab this clinical picture. So you're like Rain Man. How do you think about your risk stratification with patients with chest pain? Because this is my pet peeve. I'll rant a bit if you want. When people push on the elderly lady's chest as hard as humanly possible, and they're like, does that make it worse? And she's like, yeah, it does. And it's like, not cardiac. It's like, okay. Because that's not really specific nor sensitive in a very robust way. So how would you look at this patient and ask specific questions when we know it's extremely hard to diagnose this in the pre-hospital setting? You need diagnostics to do it.
Yeah, I think really you're not looking to really nail down this diagnosis. You're just looking to reduce the level of uncertainty that will help you go down a treatment pathway to, keep that patient safe, right? And I think, you know, all the paramedics out there, they know how to, start off with a differential diagnosis and narrow it down based on their questioning, and they're going to develop their own kind of pathway for that with these patients. Um, like we talked about, stacking those risk factors on top of one another, having those like kind of key physical exam findings and complaints from the patient. And then you can add on top of that, ECG. So we're going to do a 12 lead ECG on all our patients that have chest pain, shortness of breath. I hope so. Or even just shortness of breath. You can start finding things like flipped T waves in the inferior and anterior leads, which don't really make sense for a occlusive event, but are a sign of RV strain. You might also find things like an incomplete right bundle branch block, which is also going to be more indicative of RV straining. You can see how keeping things broad and having a good, keeping your index of suspicion high for this disease will help you, potentially not miss it down the road as you move down this pathway with your assessments.
I'm just thinking how this is what I did. So you're a female patient and you're on oral contraceptives. Check. You're meeting these things. Do you smoke? Check. It's like, okay, the risk just gets higher and you have no other comorbidities. It's like, okay, have you traveled recently? No. Then we look at physical signs and symptoms. Like sometimes they'll have that cyanosis in their fingertips, sometimes even centrally too, depending on how many clots they have, how big are the clots, and how much of a dead space they are experiencing. Because you said it, it's not a ventilation problem per se, it's a perfusion problem. So you kink off a hose that obstructs the water, just like clot in your vessels would obstruct blood flow distal to that area. So I think the key thing is too, that a physician mentor said this to me once. He goes, you know how hard it is to diagnose these conditions in the pre-hospital setting just by instant history alone and physical findings, even ascertaining shock states, because they've seen our exams. Hey, what type of shock is this experience? And they laugh. They're like, you know how hard that is to do in real life? And I was like, oh, sorry, Mitch. This is how I was trained. But I think that's why knowing the patho and understanding the risk factors just builds you your evidence to say, I have a higher likelihood of this because of these reasons versus this condition for those reasons.
Exactly. Because, I can go there as a massive like PE nerd and think, this patient has a PE, great. I'm going pretty confident in that. I've gone through my history, my exam, my vital signs, and I'm pretty sure this patient has a PE. Then we get to the hospital and they have a negative D-dimer and they had something else. Perfect. Okay, cool. And pneumonia. Great. And that feedback helps me further develop as a clinician. So, you're going to be wrong, but sometimes, but it's all about just developing that clinical acumen over time and not having that kind of anchoring bias with your complaints, where your patients are, your anchoring bias for your diagnosis. So, 50-year-old male patient with chest pain is always an MI. Well, could be this too.
And we pretend this doesn't exist in the grand scheme of things because you're affected and biased by the recent calls you've done. You're affected and biased by the things you've seen and read. You're affected by listening to this podcast, hearing these two idiots talk about PE, and that could affect how you look at the next calls, right? That anchoring bias. And that's why we all recognize in the pre-hospital setting that it'd be nice to get outcomes, because we know if I was correct, if I was off, if I was kind of correct, because then you could truly develop and learn. Because I've had the same experience. I thought someone was septic. I went back and checked on them and it was pancreatitis. It wasn't sepsis. I'm like, well, I'm a moron. So we have to recognize that it is hard in the pre-hospital setting. We'll never be 100% sensitive or specific, but there are clear risk factors for this disease. And again, it's fairly common. And my suspicion is that we underthink it is a PE and possibly don't have the appropriate treatments for it, which is okay if they are a hard diagnosis and need to get to the hospital.
Absolutely. And, as potentially more diagnostic modalities become available in the pre-hospital setting, our sensitivity and specificity for this disease could improve in the pre-hospital setting. So, if you want to have a good rule out test, point of care D-dimer machines are available out there. If you have iStat in your service, you can just do a D-dimer. That's great. If you have POCUS, that can also start, not only looking for the signs of PE, but looking for the absence of signs of something else. And that can help you kind of narrow down what could be happening. I think, it's really important for paramedics to be in a position to advocate for these patients when they do perform their triage report, their report to the receiving staff. I'd like to briefly touch back on a little bit of the pathophysiology, because that's going to be super important for kind of the follow-up in the hospital. And having a really good understanding of that can help you prevent harm in these patients. So, why does PE cause such profound refractory hypoxia? So we talked about how this causes, VQ mismatching, right? And maybe paramedics don't remember VQ mismatch. So your VQ ratio is your ventilation over your perfusion. So COPD causes a decreased VQ ratio because your ventilation is going to be affected, but your perfusion in theory is not. We know there's compensatory mechanisms, but we won't get into the weeds. Whereas PE does the inverse. Your ventilation is not affected. There's nothing wrong with bronchial tree whatsoever. But the perfusion in the area, the segment of the lung that's affected, is 0. And this could be obviously some segmental, or, the entire, structure. Now, this means that there's dead space. It's like if, we talk about anatomical dead space all the time with like the parts of the lung that are not participating in gas exchange. Well, now you've just functionally made their lungs way, way smaller in terms of gas exchange, right? So even with supplemental oxygen and aggressive oxygenation, these patients may remain hypoxic, just because there's nowhere for that gas exchange to occur.
Why does the clot get stuck in the lungs? Why doesn't it just keep going?
Yeah, I mean, we do get this question, but kind of fundamental anatomy is that you're going to have your pulmonary arteries going to get smaller and smaller and smaller. It's going to go into capillary beds. There's absolutely no chance of getting through the capillary beds into the pulmonary veins back to the heart. That's just not going to happen. So the only way that it can go systemic is if it goes through the heart somewhere, which is, an ASD or VSD.
And that connects to what you were saying earlier, that if you don't have those abnormalities, it's going to get stuck in the lungs because nothing could sit through that small capillary that's the size even of a microclot. It'll just get stuck.
Absolutely. Yeah. And, one thing that's interesting to think about is the hemodynamic consequences of this, right? Because the cause of death for these patients is actually not the hypoxemia. It's the sudden catastrophic RV failure, right? So your right ventricle is used to moving a high volume of blood through a nice, relaxed pulmonary vasculature, right? And it's even aided by the negative inspiratory pressure that causes negative intrathoracic pressure that kind of like helps pull blood from the RV. So the RV is pretty weak-walled ventricle, not ready to take on a 10x increase in its afterload from a increased pulmonary vascular resistance that can happen with a clot. And interestingly, the increase in pulmonary vascular resistance that you get from a PE is not congruent with just having that piece of the lung occluded. So let's say like if I collapse your lung, just like 1/4 of your left lung, that will obviously increase your pulmonary vascular resistance because we have a smaller circuit. But the clot has a bunch of nasty chemical mediators in it that cause vasoconstriction, because that's a part of the clotting cascade. So when your clot gets launched in the lungs, it causes massive vasoconstriction throughout the lung parenchyma as well. So that dramatically increases the pulmonary vascular resistance. So you can think about there's so many factors that are going to be going against that RV, leading to catastrophic failure. Given that the RV is in a series with the LV, if you have complete RV failure, you have no cardiac output and your patient goes to the PEA.
And what do we do to compensate?
Often, as clinicians, we're going to be trying to increase our patient's perfusion. The first step in doing that usually is fluids. And then we're going to give them some volume expansion, which will further dilate their right ventricle, further lead to, that failure there as well. When you dilate your right ventricle, it will start shifting the intraventricular septum, which can then start impacting the left ventricular outflow tract and decrease your LV output as well. So some of the treatments that we and the hospital team may start providing for these patients, given their fact that they're hypoperfused, may actually make them worse quite acutely.
How would I know that though? Because in the pre-hospital setting, Jakob and Ryan, you told me it's really hard to diagnose this in the pre-hospital setting. And if I have someone that's hypotensive, there's a consequence if I don't give them fluid as well. If I leave them impaired with poor perfusion.
Yeah, and I think this is where paying attention to your patient's response to treatment makes the most sense. So, in adult patients, we give 250 ml boluses at a time, and we're supposed to reassess not just that their blood pressure is normal, but also reassess, like, is their heart rate coming down? If there's signs of perfusion improving, if they're give a 250, then you give them 250 and their blood pressure is decreasing and their heart rate's increasing and they're more hypoxic and they look worse. What's going on? Like, something's wrong. So maybe that can also be a trigger to, make you think about this diagnosis and make you think about ways to manage this further.
So what I hear you saying is that, there's risk and benefits to everything. And truthfully, we don't know if we'll have a response until we do it and diligently reassess the patient by a multitude of factors, not just, hey, I auscultate the chest every 250. It sounds great. But did your heart rate actually come down? Did your color improve? Did your mentation improve? Or is it like, you look a little worse? So why are you unresponsive? Or is it just incidental? You're getting worse. And that's the problem with healthcare. Medicine's hard. If I do something and you get worse, is it truly a factor that what I did made you worse? Or is it just the nature and the progression of the disease? It's hard.
Yeah, because you can absolutely have your septic patient that you give fluids to and they get worse for a little bit and then maybe they'll get better later on. And the answer in that patient would have been to keep giving fluids. But, like you said, medicine is just really hard. And I think it's stacking up your pre-diagnostic probability with those risk factors with the clinical exam and then the response to treatment that can start to narrow things down and help you think about the next steps in managing this patient. Another thing that you can do that's cheap, easy, amazing is provide as much oxygen to these patients as possible. So this can help decrease your pulmonary vascular resistance and spare that RV failure that's developing. So if you're quite sure that it is a PE, providing that super high flow like oxygen can help decrease that pulmonary vascular resistance and potentially help prevent decompensation in your patient. That'd be great. Obviously, we live in a world with quite a bit of uncertainty. So what do you think in terms of like patient safety for those treatment approaches?
We can try, if they're indicated, for fluid and see if they're fluid responsive and be very judicious with fluids. And again, see how they are responsive or not, because there is a consequence if I give it to them or not. And all depending on the patient, the context, it's hard to say. Can you give a blanket statement? Then I think it's important to get them to the hospital as soon as possible. Because again, how far away are you from the hospital? What's their map? Because we talked about how from a patient safety lens and pre-hospital perspective, patient handover is everything. We do it 20 times a shift. And having that discussion, proper, robust handover to the receiving staff is everything too. This is likely a PE due to these reasons. This is why I'm thinking it.
Absolutely, because if there isn't that really good handover, then all the receiving staff has is a critically ill, hypotensive, hypoxic patient on their bed with not much of a story. And what are they going to do for that patient? They're going to volume expand. They're maybe going to start vasopressors, and then they're probably going to quickly move to, an advanced airway treatment like RSI. And then RSI is going to be extremely dangerous for these patients. Why? So, right. Well, we talked about how the negative intrathoracic pressure caused by negative pressure ventilation, so spontaneous breathing, is one of the mechanisms that are really preventing that RV from completely failing. So with RSI, you're paralyzing the patient, you're getting rid of that negative inspiratory pressure, and then you are providing positive inspiratory pressure on top of that. You're probably going to be going down like your FiO2 PEEP scale. So you're going to be increasing your FiO2 and your PEEP together. And then as you increase your PEEP, you're going to also increase your intrathoracic pressure. All these things are going to lead to further RV failure and RV strain.
So even in our context, I don't have RSI. And if they do need to be intubated for whatever reason, how do we do it?
Yeah, this is where the classic doctrine of resuscitate before you intubate, you're going to want to make sure that they are maximally oxygenated, that they have the, hemodynamic support that they need. So you give a little bit of fluid, saw that didn't work. And then, preserving the negative inspiratory pressure is huge for these patients. I was just doing everything to prevent that negative inspiratory pressure from being lost.
Again, it's showing the complexity of this patient. There's a lot of decisions and thought that has to go into this.
Absolutely. Yeah.
So I'm just thinking, well, if you're the in-hospital setting and you have an algorithm, or pre-hospital settings around the world that have these options, it's like, this is my working diagnosis. These are the drugs I should give, or these are the drugs I should avoid for these reasons. And we have to optimally give them oxygen, fluids if need be, vasopressors, whatever choice they have. That's a lot of things to do that all have competing priorities.
Yeah, and you're going to be doing that as probably one brain in a moving vehicle, and you're going to have to do all of these hands-on skills at the same time. So you are starting the IVs, you are initiating monitoring, you are drawing up these drugs and doing this airway, all at the same time, and then can increase the risks of, patient safety incidents. So what do you think are good systems level kind of changes that we can make to reduce the risk of iatrogenic harm in such critical, complex cases when, sometimes even if the IQ is 1,000,000, the human brain is not enough?
It is not real valuable, especially if we don't review Ps that often. It's not our first thought process in it. It's really hard to diagnose. And again, like you said, if we have one brain in a complex patient that's in a moving ambulance with lights dimmed, loud sirens going off, a lot of human factors are in play here, and you can see we'll get overloaded quite quickly. And at this time, we have the base hospital physician as a consult, which is good patient safety, but that takes away time and resources and more mental acuity. It may be hard to hear the physician. That's a barrier. So I'd say just easy, reliable patching and have that ability to consult, and even just a perspective shift of maybe seeing as calling as a hindrance, and more it's like, no, this is optimal. Because Orange does that. They call their physicians, they review their medical directives, the patient very robustly, then they have a plan. So it's that multi approach that you can have somebody back you. That's a higher medical authority. I think just using as much resources as possible. Hopefully your partner's there. You say, this is what I'm thinking. What am I missing though? So you bring them all in, have that shared mental model, and you can go through the risk stratification, working diagnosis together. So you're on the same page. It's not like, hey, I don't know what you're thinking or doing. I'll go drive now. Culturally,
absolutely. And I'm so happy that culture shift is happening where it's really two brains on every single call. It just happens that one goes to drive when it's time to leave. I think that's excellent. And I think your notes on that patching and having that consult patch is huge, because we're really shifting from, I'm patching because I have a mandatory provincial patch point. That means I need to patch before cardioversion or whatever, right? It's more just, I have a super complex patient. I have a couple ideas of what I could do to help. I have a long transport time, and I'd like to just get someone else's opinion on this that, by virtue of their training and their roles, probably have a lot more reps with these patients than I do. So we can, have an informed and collaborative discussion on the best way to manage this patient. And sometimes that'll be, you're kind of out of tools, and then you can't really do anything right now, but you tried. And sometimes that'll be a list of procedures and treatments to provide for that patient, but you're going to be like empowered by that consultation. Yeah, I think that's a great shift in the culture of paramedicine in Ontario, especially.
Yeah, and I think we need to recognize, just because you asked for it or didn't receive it, that doesn't mean you did anything wrong. There could be better options. Sometimes the best move isn't treating. Because you have the discussion, you weigh the risk and benefits with somebody that has a pretty significant experience and a medical degree, and they're like, hold off. And I think that's the hardest part of the human factors. As practitioners and healers, we want to do something, and it's very hard for us not to do something. And I think that's where the craftsmanship of healthcare provider, especially with more experience, knows I need to know when to intervene and when not to intervene. But just think about the dosages and everything. Let's say you do have to run a vasopressor or give fluids. Checklists. Are they the highest quality intervention from a patient safety thing? No, but it's one thing among many things we could do. Imagine having a checklist where you could review drug dosages, drugs, recommendations, how to respond, how often to respond. So right away, it's all that mental bandwidth. And if we go back to, if you're typically working with a partner, before they go driving, pull in context again, why don't you offload some of your tasks? Hey, you're IV certified. Why don't you do the IV for me? Hey, do you mind setting up the oxygenation, the resuscitation kit if need be? I'm going to make this patched and formulated in the SBAR format, IMS-AMBO, whatever you want. So right away, you're kind of offloading things you can control because it's that shared mental model. Then the one thing is I need to do based on priority for this context of this patient, I will do this. And why don't you go through that strategy together? These are the priorities. This is what I think we need to do first, but what am I missing? And bring everyone in. I think that's what things we could do tomorrow.
And I think when you create that shared mental model with your partners, it's pretty amazing how much stuff you can get done in like very little time. You can be in the back of that ambulance and give them like 3 tasks to do. You patch. By the time you're done patching, you've got a line, you've got your oxygenation stuff, you've got all your equipment ready to go. They go drive. Like that might have taken you 5 minutes, and now you have a solid game plan and a good foundation to execute it.
Because we talked about this before. One of the biggest gaps that's a hard problem to solve. Like if I could wave a magic wand, it'd be having medication dispensers in the ambulance and you can scan your medicines because you can confirm it. Because the gap is, if it's just me in the back of the ambulance and you're driving, I have no one to confirm those med with. While you're blasting sirens, the lights could be pouring, bouncing around. You can see how easy it is to get distracted and not read the correct label or pick the wrong med. So if we can do that, it's like, hey, I may have to give these meds, or do you mind confirming them? That second option, confirm the medication with me. That's a way to do it. Or just find other system changes to ensure you get the correct med, which is possible, right?
Mm-hmm.
But then just thinking, we always tend to patch while driving, and you can see the microphone wires tangled around the steering wheel. You're trying to go through an intersection. It's like, this is awful. I just started patching before we moved. It's like, let's just patch here, tell them, then start driving. If you think about a patient safety and paramedic risk and the public risk that we patch and drive and go through stop signs and red lights when it's safe to do so, but we're doing all that, we know humans are inherently suboptimal at multitasking. It's like, that's an easy fix now. And it takes 2 minutes to patch.
Yeah, and when I used to work more rural and had like really long transport times, and I had time to do this, I'm not sure if it's the preferred method, so I won't say which hospital or anything, but I would call the charge phone and give my patch over the cell phone, because then we can have a back and forth conversation for like 5 minutes about the patient if we need to. They can have like everything they need before we get there, instead of like a really quick radio patch that's like staticky and one way, right?
I'm glad you said that, because these are little things, but they're probably huge system changes. If you want a huge patient safety lens, communication, like we said, is everything. Why don't we wave a magic wand or do whatever system solutions we need to improve our audio or reception? Because how frustrating is it you're trying to call the base hospital physician on a phone that was created in the early 2000s, that's a flip phone, and no one can hear, and you're trying to get orders on this very sick patient? Right away, you're frustrated. You're going to get more aggravated. It's going to impair your performance. The physician's frustrated. What do we do then when that's one of our main ways to confirm and validate orders?
Yeah, there's a lot stacked up against that medic trying to manage these patients. There's no doubt about that. And then, there's some factors that you can try to mitigate, use your own phone, use some earphones like the ones you're wearing right now that can help you kind of noise cancel it and hear, have a more clear conversation. That won't help you in your low service areas. That won't help you inside some concrete buildings. So there's always going to be that variability. And I think that's what makes paramedicine so challenging, is providing, complex critical care to patients at the point of injury or illness, on top of all the logistics and environmental challenges that we deal with. But what's pretty amazing is that most of the time, this is executed well and patients are getting really high quality, safe care. So, giving kudos to the paramedics out there doing that right now, facing those odds.
You can see that's why the moral injuries come in. Look how much I have to combat against system problems, and I'm supposed to provide patients the safest care and effective care as possible with all this stacked against me. You can appreciate it, why it's frustrating. I was frustrated. I want to jump out the ambulance sometimes just because I was so frustrated. But there's things we can do. And I'm just thinking, like, I had to review this for another project I had to do in school. Imagine you had an app or a platform where it was secured, it was confidential, and you could access it regardless of source of data. You could interface with the base hospital physician, receiving physician, send pictures, send patient vitals, send a story, a voice note. There you go. It's out there. Technology's there. We just got to leverage it if we can. There's a lot of hurdles to get through that.
Absolutely. Like, that's clearly an important part of the answer, right? Like the post you made today, that's like, we can't train our way out or educate our way out of every patient safety risk out there. We need to develop, engineering and IT solutions that will help reduce those risks, because patients never fit a medical directive perfectly. You are still going to have to think through the case, get a differential diagnosis, weigh the risk and benefits for that patient on an individual basis. And we talked about today how to manage pulmonary embolism. And paramedics are doing a really good job at managing this and diagnosing this. But there's no pulmonary embolism medical directive out there. It's being done. They're just managing it based on clinical knowledge, and maybe a bit of a system shift in that sense could be useful.
That's the medical directives are based on the most recent updated best practice guidelines and evidence. And you can't fit everyone into the same medical directive. You can't write every single medical directive for every single condition. It's hard. And it's literally the most simple, but sometimes frustrating quote when they say medicine's hard, because it is. It's exceptionally hard for anyone.
Yeah.
And especially when we have insufficient system changes. But this is where amazing people's work's coming in and improving that, because we always can do better.
And I think I'd like to just end on the point that paramedics are providing really high quality and safe care for patients, despite systems barriers, despite, a lot of challenges out there. They can be really proud of the work that they're doing, and can hope to continue improving the system for higher quality care and safer care for our patients.
It can always get better. Everything's iterative. And just because we point out some things doesn't mean anyone's doing anything wrong. It's just healthcare is up against many different factors, and it's very hard to make system-wide changes with so much complexity and difference in all the different types, whether it's pre-hospital, in-hospital. But having these conversations and thinking about the problems is a good start.
Absolutely. Like, when you think about just making any change in the system, it just makes my brain explode how complex it is. So it's definitely going to be a community effort.
And as you are learning currently, change management is an enormous skill, and 70% of all healthcare initiatives fail because it is so hard to change.
This channel and its content are created independently and not affiliated with or endorsed by any employer, agency, or organization. The information provided is for educational purposes only and should not be considered medical advice. Viewers must follow their local paramedic guidelines, clinical standards, and applicable laws when providing patient care. Always practice within your scope of practice and seek direction from authorized medical oversight when required.